national and international conferences. His special areas of interest are infectious diseases in transplant patients, bone health in kidney transplant recipients, and IgA nephropathy. And today's talk is on advances in primary glomerulonephritis. Welcome, sir.
Good afternoon, everyone. I would like to thank the organizing committee for giving me this opportunity. Actually, it's nice to be back again. I was part of the first medicine annual conference way back in 2016. I was taking care of the accounts and I had handed over to Dr. Vignesh. Now he is the organizing secretary for this. That makes good. So next 20 minutes, I'll be talking about the updates in primary glomerulonephritis. The reason is that the topic is very important because we might come across these patients either before diagnosis or during the treatment or at follow-up or maybe due to side effects of any of those medications which we use. So I think it's just before lunch. So I will try to summarize this talk in 16 update points to make it simpler for us to understand. So coming on to minimal change disease. I think this has been mentioned previously by Susna in her talk. This is one of those Neptune cohort. This cohort actually they enroll all children, adults with FSGS, minimal change disease, and membranous nephropathy, and they follow them as a longitudinal cohorts. The advantage of this is they follow them up and they use the treatment. They assess the treatment response and their outcomes, and they're able to get the molecular markers in nephrotic syndrome, and they are able to do the targeted treatment. One of the paper from their cohort is that discovery of autoantibodies, which is targeting nephrin, which suggesting a role of autoimmune, possibility of autoimmune etiology in minimal change disease. They found out that 1/3 of those patients with minimal change disease had a circulating nephrin autoantibodies, which is an important discovery from their cohort. So what we knew before is just animal models, but what we come to know from this cohort is the role of anti-nephrin antibodies in humans with nephrotic syndrome. And they are also looking at urinary biomarkers to predict steroid resistance. Next important thing in nephrotic syndrome is use of repeated rituximab infusions to maintain remission in childhood onset nephrotic syndrome and also with adult nephrotic syndrome. This study showed that children receiving repeated courses of rituximab had shown sustainable response and relapse-free period. Even the newer guidelines compared to what was described, I think it's not clear, compared to what was described in KDIGO 2012, the recent developments in patients who had a contraindication to use steroids, rituximab may be a safer option, and those with frequently relapsing steroid-dependent nephrotic syndrome, rituximab may be alternative over cyclophosphamide. So what we know from this update is rituximab may be an effective and relatively safe alternative for most adults frequently relapsing steroid-dependent nephrotic syndrome, but we need more prospective studies. Next thing is on focal segmental glomerulosclerosis. So what we know before is, I think we have studied since pathology, the Columbia classification of FSGS, FSGS not otherwise specified, and other types. The update is that with the newer circulating biomarkers available and with the discovery of anti-nephrin antibodies, the newer the classification, the proposed classification is a primary FSGS, which is also called as immunological FSGS. And there will be it's known to have a circulating soluble factors. That the importance of this is there is a benefit of giving immunosuppression to this primary FSGS. Next important subtype is a genetic FSGS, which we had discussed it before. And third important subtype is a secondary FSGS. So the important thing to know is only primary or immunological FSGS, which is known to have a circulating factors, will be respond to immunosuppressions. So what we know before is a Columbia classification. There is no correlation between treatment response and does not always distinguish between the primary and secondary type of FSGS. What we know is the subtype of primaries, genetic, secondary, and undetermined cause, and immunosuppression only in primary FSGS. Another important drug which has been recently studied is the sparsentan in FSGS. It's a novel immunosuppressive, novel non-immunosuppressive dual endothelin and angiotensin receptor antagonist. As we know, angiotensin 2 and endothelin 1 has effects on acts on podocytes, and it can cause proteinuria and ultimately causes progressive glomerulosclerosis. So this is a sparsentan which was compared with irbesartan. What they found out is patient in the sparsentan had more partial remission of proteinuria when compared to ARB alone, but there was no difference in eGFR slope. A lot of other molecules which has been studied or being studied for FSGS. One of them is anti-CD20 monoclonal antibodies and sparsentan and transentan. A lot more molecules are being studied but not yet approved. So one of the important molecule from which has been studied is recent molecule which has been studied is sparsentan, which is a novel non-immunosuppressive dual endothelin and angiotensin receptor antagonist, which has a benefit over ARB. This is one more new drug which has been studied to inhibit the APOL1 channel function, inoxapaline. Inoxapaline, in those with APOL1 variants, they tend to have more poor prognosis. This inoxapaline is the one which is an inhibitor of APOL1 channel function. They found out that there is a decrease in proteinuria, which has been seen in those with non-nephrotic and nephrotic proteinuria in those with APOL1 function. So in those with APOL1 variant, inoxapaline is the drug which is being studied, but we need more studies and long-term adverse events are yet to be known. Coming on to membranous nephropathy, all of us would have come across with patients with membranous nephropathy. The second most cause of nephrotic syndrome after diabetic kidney disease. It's characterized by subepithelial immunoglobulin G deposition, which causes damage to the basement membrane, and there's the podocyte food process effacement and high-grade proteinuria. One of the greater discovery in membranous nephropathy is the circulating antibodies targeting the podocyte antigens. Way back in 2009, PLAT2R was discovered, which has led to subsequent discovery of a lot of more podocyte antigens in the near past. So kidney injury is mainly caused by the damage to the podocyte and GBM rather than inflammation in membranous nephropathy. There's a role of genetic predisposition and suppression of regulatory immune system. One of the important discoveries is the antibody secretion against the podocyte antigens. So over the last 5 years, more and more new podocyte antigens have been discovered against which antibodies have been formed. And the importance of this is there is a specific association of this podocyte antigens with certain causes. The commonest podocyte antigen we see in primary membranous nephropathy is the PLAT2R. It accounts for 70% of primary membranous nephropathy. Next most common is NEL1, which has been associated with malignancies, and exhaustion has been associated with autoimmune etiology. So the advantage of identifying the autoantibody against a specific podocyte antigen is we'll be able to have a disease association. That's very important. So the proposed new classification is you identify the membranous nephropathy antigen and to associate the disease along with it. Hence, so like say NEL1, it has been associated with malignancy, drugs, and autoimmune disease. I would like to highlight this paper from Chennai, one of the alumnus from here, Dr. Anila Kurian, which was published in Kidney International 2 years before. She's a pathologist. So what they found out, they tried to characterize all those with membranous nephropathy by diagnosis. So 1/3 of them had history of traditional medicines that contain mercury, such as Siddha and Ayurvedic medicines. So they did the podocyte antigen. What they found out was majority of them had NEL1 positive, and median duration of use was 5 months. And once they discontinued those medications, there was a remission happen. So important highlight of this paper is NEL1 association with traditional medicines. Mercury can interact with negatively charged GBM, which can alter the GBM structure and cause proteinuria. So the way forward, which may not happen in the near future, is the targeted approach. So we do a PLAT2R first and NEL1 second, which is the most common podocyte antigens against which antibodies are formed. Then you, based on the associated disease, like autoimmune disease, you do exhaustion, malignancy, you can do thrombospondin 7A, and subsequently we can do specifically for the disease association. That's one way of targeted approach. Second thing is a panel approach. You start with PLAT2R, NEL1, and then go on to more commoner podocyte antigens, then go on to rare podocyte antigens. Third thing is a proteomic approach. It's mostly on research based. The discovery of PLAT2R and other novel target antigens, and the 3 approaches to approach a patient with membranous nephropathy. Coming on to treatment of membranous nephropathy, it's very important to characterize the risk of progression to end-stage kidney disease because it is a potentially treatable condition. If you don't identify early then and treat appropriately, it can lead to end-stage kidney disease. So those with very high risk with nephrotic syndrome or life-threatening nephrotic syndrome or rapidly deterioration of kidney function, we need to start give glucocorticoids and cyclophosphamide. Those with moderate and high risk, we might have to we may not be able to wait and watch. We have to start immunosuppressions. With low risk, we will be able to wait and see. So one of the important drugs which has been studied in the recent past is a rituximab in membranous nephropathy. There are numerous trials. One of the important trial is a Mentor, which is a larger trial which compared with cyclosporin. And if you look at the remission rates and the relapse-free intervals more with rituximab. Relapses were more with cyclosporin and the less remission with cyclosporin compared to rituximab. So the update is rituximab is superior to calcineurin inhibitors in membranous nephropathy, but non-inferior to cyclophosphamide. Going on, next update is the treatment response in membranous nephropathy. We have a gentleman with plateau positive membranous nephropathy. How do you assess the treatment response? So this assessing a plateau classifying the risk based on the plateau levels helps us to decide whether to start immunosuppression therapy or whether to modify based on the serial follow-up and to consider refractory and change the treatment further. So the plateau levels in the serial basis will help us to assess the treatment response and to decide on starting immunosuppressions. So this is a study which supports that they felt that antibody-guided therapy is more effective in patients responding to 8 weeks of cyclophosphamide-based therapy. This is a Mentor trial cohort, which I had mentioned it before, which studied rituximab versus cyclosporin. The thing I want to highlight is the model which they created after 3 months based on the change in plateau antibodies and change in albumin levels predicted a response better than the baseline or 6 months model. So the update is plateau can be used in monitoring therapy and predicting relapse, one, and model at 3 months is more important, found to be better than the baseline model or 6 month model, and longitudinal change in parameters is more important to assess the treatment response. These are the other agents being used in membranous nephropathy. I'm not going to spend time because it's not yet approved. More trials are going on. Coming on to C3GN and atypical aHUS. As we know, it's a devastating illness. It's quite uncommon, but patients with C3GN or atypical aHUS have poor kidney outcomes, and there is a high risk of transplant recurrence of the disease in renal allografts. So it has a clinical course is defined by proteinuria, hematuria, and progressive kidney disease. Most patients reaching end-stage kidney disease within 2 decades. This is the pattern of injury we see is either it may be a membranoproliferative GN or mesangial or endocapillary proliferative GN. The current standard of care which we use is supportive measures for patients with mild disease. If they have moderate to severe disease, we give mycophenolate plus steroids. So the new update is the complement inhibitors. We have pegcetacoplan or iptacopan. Iptacopan binds with factor B, and pegcetacoplan inhibits C3. So this is a study which looked at pegcetacoplan, which is a targeted C3 inhibitor. They found there is a decrease in proteinuria. And there is a study which looked at iptacopan, which inhibits factor B. They found the preliminary results are available. There's a 35% decrease in proteinuria reduction compared to placebo. So what we know before is steroids, mycophenolate, and RAS inhibitors. The newer update is the complement inhibitors. Advantage is it's a pathogenesis directed therapy will be more effective, but the cons will be the availability and affordability of those medications. So next thing which I need to highlight is the atypical aHUS. So one of the treatment of choice is eculizumab. The problem is how long to give, and the cost and getting the medicines is difficult. So this trial which looked at they had tried to withdraw the eculizumab at 3 months, median of 13.6 weeks, and looked at relapses. Relapses occurred only in 4 out of those 18 patients, and for them they have reinitiated within 24 hours of all relapsing patients. So what they highlighted from this paper is there's a cost reduction of 70% in those who had they have stopped, withdrawn the eculizumab after 3 months. So reasonable option, if the problem is the cost and getting the medicines, minimum treatment of eculizumab might be good. And in those patients who relapse, you restart the eculizumab. So as I said already, there's a high rate of recurrence of atypical aHUS in those who had a graft loss due to atypical aHUS when they go for transplant. So this is a study which you studied the use of prophylactic eculizumab in those patients with atypical aHUS on renal allograft survival. So the recent advance is that in those with higher risk of early recurrence, means high risk of recurrence, like people who had previous early recurrence following transplant, they have a pathogenetic mutation or a gain of function mutation. Then there's a role of starting eculizumab, start on the day of transplant and continue it to monitor the kidney function. So newer update of that is the role of prophylactic eculizumab in kidney transplant recipients. Going on to Alport syndrome. Alport syndrome is a hereditary kidney disease with a defective GBM with caused by mutation type 4 collagen genes. There are a lot of new drugs which have been studied, but more important thing I want to highlight is the timing of starting ARB in Alport syndrome. This has been recently studied in PROTECT study and Japanese cohort. So what they say is in boy and men with X-linked Alport syndrome, better to start at the time of diagnosis, the ARB to be started at the time of diagnosis, and all those either gender with autosomal recessive. So the male with X-linked Alport syndrome, either of the gender with autosomal recessive Alport syndrome, you should start ARB at the time of diagnosis because it is known to cause delay in kidney failure in 17 years in those with milder Col4A5 variants and 12 years in severe Col4A5 variants. So there is a definite need to start ARB irrespective of the proteinuria in those with Alport syndrome. Other important thing from that study is that there is a good genotype and phenotype correlations. Those with missense mutations and non-truncating mutations had a better outcomes. So genotyping might be useful in those patients. So the update for the Alport syndrome is start as early as possible males with X-linked Alport syndrome and either with autosomal recessive Alport syndrome. There's a good genotypic phenotypic correlation. Newer agents are being studied, but not yet completed. Coming on to IgA nephropathy, which is the most common cause of primary glomerulonephritis. There's been a cohort which is studied in our department itself. We have found out compared to Western population, our patients have poorer outcomes. They have more chronicity to start with. So the early identification and appropriate treatment is very crucial in IgA nephropathy. And it's we often see patients who had come with significant chronicity before when diagnosed the IgA nephropathy. Last 4 to 5 years has been a lot of progress in the IgA nephropathy with a lot of new molecules being studied. One of the important thing to highlight in IgA nephropathy is the 4-hit hypothesis. The first hit is the increased circulating galactose deficient IgA1. Second hit is the creation of antibodies against galactose deficient IgA1. Then there'll be a formation of immune complexes. Subsequently, there'll be a deposition in kidneys leading to glomerular injury. So there are molecules which are being studied at different levels. I'll come to that. So one of the important drug which has been updated in the recent guidelines is SGLT2 inhibitors in IgA nephropathy. In those patients who are already on maximal tolerated of ARBs or ACE inhibitors, one of the important drugs is the SGLT2 inhibitors. I think Sir has already said about EMPA kidney and DAPA-CKD trial. The latest trial is EMPA kidney trial, which had more non-diabetic patients were included, more patients with glomerular disease were included, and even lesser GFR, patients with lesser GFR also included, and lesser proteinuria also included. So the thing I want to, definitely it was a positive landmark trial which showed there is a decrease in progression of kidney disease or death from cardiovascular causes compared to placebo. The thing I want to highlight here is the subgroup analysis which included IgA nephropathy. The significant number of patients were included, and it was a positive outcome, and there was a statistically significant improvement in kidney outcomes in EMPA glyphosate group compared to placebo. These are meta-analysis which looked at which combined DAPA-CKD trial and EMPA kidney trial. Definitely there is a positive effect on kidney outcomes. So the update is what we do when there is a risk of high risk of progression. The update is the addition of SGL2 inhibitors. It's a larger trial and more promising evidence, and it's consistent with DAPA-CKD trial. Next is the use of steroids in IgA nephropathy. Let's say you start on ARB and SGL2 inhibitors, still they are at high risk of progression. What will you do next? So one of the trial which has been recently published in last 2 years is the low dose testing protocol. Initially, they started with high dose steroids where they had a lot of infectious complications. Methylprednisolone 0.6 to 0.8 it started with. Then they had decreased it to 0.4 mg per kg for 2 months and tapered it, and they added cotrimoxazole. So with which they found there was a significant difference in the primary outcome between the methylprednisolone and the placebo group. And so they also found out there's a difference in cumulative incidence of 40% decrease in GFR and kidney failure and death due to kidney disease. So that is a low dose testing trial. Other important trial which has come out is the budesonide, targeted release formulation of budesonide. We don't have this molecule in India, but we have a similar molecule which available in India. So they looked at patients with high risk of progression because it targets the pair patches. So it targets the first hit of the IgA nephropathy, which we discussed before. What they found out is use of targeted release budesonide in patients with IgA nephropathy. There was a clinically reduction in eGFR decline and durable reduction in proteinuria compared to placebo. And it's also it's well tolerated and safety profile. So what we have for patients with high risk of progressions, despite on maximal ROS blockade and SGL2 inhibitors, either we can enroll them into a clinical trial or we can start them on low dose steroids or targeted release budesonide. Next drug which has been published recently is a sparsentan, which was already discussed in FSGS. They found out that definitely there was a decrease in proteinuria from baseline compared to irbesartan, and it's a PROTECT study which showed that there's a decrease in proteinuria and there is a slower rate of eGFR decline compared to irbesartan group. So the update is that people who are on high risk of progression, one of the drug which can be used, it's a non-immunosuppressive drug which blocks both endothelin and angiotensin receptor. So other important update in IgA nephropathy in the recent times, in the last 2 years, is the use of BAFF and APRIL inhibitors. So what they do is they are the cytokines which are involved in B cell signaling, and they are all involved in the production of galactose deficient IgA1. So if you target the first hit in the IgA nephropathy, the downstream events do not happen. So these are the trials which had looked at APRIL and BAFF inhibitors, sibeprenlimab, and followed by atacicept. We were also part of this trial, this multicentral trial. So there was a significant stabilization of GFR with reduction in proteinuria in those APRIL and BAFF inhibitors. There is a role of complement also in IgA nephropathy. There is a glomerular C3 deposition correlated with disease progression, may be observed in 71 to 100 patients. And coexistence of thrombotic microangiopathy in IgA is a significant indicator of poorer prognosis. There are agents which had been studied. One of them is iptacopan, which is a factor D inhibitor. The preliminary reports are available, which shows that they have shown to have a reduction in proteinuria. This is only a preliminary report. Final results are still awaited. So these are the newer kids on the block. One is nephroprotection with SGL2 inhibitors, which is available and cheap, and dual endothelin angiotensin receptor antagonist, and other molecules which are newly come up is APRIL and BAFF inhibitors. This is a pathogenesis directed molecule, and there's a complement inhibitors. So we have in the recent past, we have had so many landmark trials in IgA nephropathy. That's good because IgA nephropathy is causes progressive kidney damage, and is one of the leading cause of end-stage kidney disease in India. So it's good to have all these trials coming up. But only important thing is there is no head-on trials comparing any of these new molecules. All those drugs have been compared with ACE inhibitors plus or minus SGLT inhibitors. It will be good to have more evidence comparing head-on trials, which we don't know whether it will come up, and have a personalized approach for each patient will be the next way to go. So there are nephroprotective drugs which we discussed, and there are immunosuppression or immunomodulators also available. So the things I would, before I conclude, I would like to say 2 points. One is always when you do a 24-hour urine protein, we should do with the 24-hour urine creatinine as well. It's very important. Then only we will be able to see whether the sample is adequately collected. So for women, we expect 15 to 20 mg per kg of creatinine excreted per day. Men will be 20 to 25 mg per kg per day. So let's say for a 60 kg male, we expect the 24-hour urine creatinine will be around 1200. So that is very important to say whether the 24-hour urine protein is adequate or not. Next important thing I would like to highlight to the medicine trainees is the KDIGO staging of CKD. Even though the GFR is normal in the group, the proteinuria is an early marker of chronic kidney disease, especially in IgA nephropathy. May not have a elevated creatinine to start with. They might just have a hypertension, hematuria, and a proteinuria. So the early identification and referral for kidney biopsy and early appropriate management is very crucial in terms of long-term kidney outcomes. So this is something which you should keep in mind. So these are the updates which we discussed in the last 20 to 25 minutes. Yeah, thank you.